So, welcome to Billboard Ultrasound Training Institute. Today, we are taking a question and answer session. I am repeating, this is a question and answer session. What I mean by that, this is for those who are registered with us for different server-based courses. So please don't take this as a course, but this is only a question and answer session for those who are registered with us for different server-based courses. So today we got these questions from our registered candidates. First question from Dr. Manu Priya is that I want to know how to increase the gait sample on P8. Probably this is already taken in the previous session. So this is the first question. Probably I am missing that slide. So let me go to the slide first. So I'm showing you the slide. Yes, this is the slide. So this is the slide. Probably this is not coming on screen. There is some technical glitch. Let me set that. So these are the questions for today's discussion. Sonographic difference of, these are the copy pasted questions. What I mean by copy paste is that I am pasting the questions as it is. It means that these are the words which are posted by Dr. Barpita. So Dr. Barpita is posting sonographic differences of adenomyosis and uterine fibroid. Next question is from Dr. Dinanath. How to scan ductus venosus abnormalities and cleft lip and palate in first term pregnancy. Probably I told you that these are the copy pasted as it is questions. So probably Dr. Dinanath means on term pregnancies how to scan ductus venosus and cleft palate. Now Dr. Prakash is quoting that I feel difficulties to locate ovaries in some patients due to away from the area or hidden by bowel or other structures. How to overcome in this difficulty, especially in TVS probe. So Dr. Prakash is posting how to scan an ovary if it is away from the uterus. So I'm summing up the question. Next question from SN Singh is that are depth and frame rate same? Means both are inversely proportional. Means what to do when organ is deep and to upgrade resolution. So I'm summing up the question. I'm making it easy that Dr. SN Singh wants to know whether frame rate and depth are inversely proportional and what to do to improve the resolution if the organ is deep. We will discuss these things in detail. So first, I am just giving you a short glimpse of the questions. Now, Dr. Papu is posting what is the normal value of liver, spleen, pancreas, kidneys, and prostate, how to measure. So Dr. Papu wants to know the normal value of liver, spleen, pancreas, kidneys, and prostate, and how to measure it. Now, Dr. Prakash, this is the second question from Dr. Prakash. Yes, at which axial plane we should take BPD, HC, OFD accurately, transthalamic. So now Dr. Prakash wants to know at which plane I can take accurately BPD, HC, and other things, whether it is transthalamic, transventricular, or transcerebellar. Now the last question, the name is not reflected here, is that features of testicular microlithiasis. So these are the set of questions. So these are the set of questions which we have to discuss today, which we will be going to discuss today. We will be taking these sessions, these questions rather, on whiteboard. So let me switch to the whiteboard for detailed discussion of these questions. I am having in my hand the hard copy of these questions also. It is here. So I will be having this hard copy in my hand so that I will not be missing anybody's question. So let us get started. Now switching to the whiteboard. So the first question is what was the first question? So that is why I am having this hard copy in my hand so that I will not be missing anybody's question. Yeah, the first question from Dr. Barpita is that sonographic differences of adenomyosis and uterine fibroids. Now, I am again requesting the same thing. What is that? Please post questions if you have completed the topic. Why I am saying this? I am 101% sure. I am repeating 101% sure that Dr. Barpita from Assam, I'm having location also here. Dr. Barpita from Assam has not completed gynae ultrasound yet. I'm repeating, she has not completed gynae ultrasound yet, because in gynae ultrasound, we are having a detailed class of how to differentiate an adenomyotic patch from a fibroid. If Dr. Barpita from Assam is online, she can raise the hand so that we can unmute and we can have a proof with us that she has not completed the gynecological ultrasound. Dr. Barpita, if you are online, please raise your hand. So meanwhile, what I will do, I will take a very brief. Why I am saying very brief? Because these things are already available on our server. So again, requesting, please post the questions from the topics which you have completed. So I will take a very brief of adenomyosis versus uterine fibroid, not in detail. Why not in detail? Because this thing is on our server. Now, adenomyosis, I will write in short, adenomyosis versus fibroid. How to differentiate? I am not taking it in detail. This is already on our server. Please go to the server and complete your topic, then post the question. Now the point is, first point is that the echogenicity. We have to see for the echogenicity. Now you will say what I have to see in echogenicity. In adenomyosis, the echogenicity will change because this is an adenomyotic patch, and adenomyotic patch is nothing but a patch of the endometrium, which is hormonally related with the adenomyosis, endometriosis. When patient will bleed, this will also bleed. So that way, which is already on the server, which you have not completed yet, the echogenicity will change. But here in fibroid, it will be static. So this is very important point, the echogenicity. Now the size. Second is size. What will you expect in case of an adenomyosis? It will change. This is in detail on server. This will change. Why it will change? Because when patient is bleeding, the blood will pool up over there, it will increase. When she will menstruate, she will also shed the adenomyotic patch. And there are a lot of things when she will bleed an adenomyotic patch, when it will increase, when the volume, not the volume, the pressure will increase over there. There will be the intermenstrual bleeding, which is in detail in our class. So second point is the size. The size here will not be static. I am making a cross for this size. It means that this will not be static, whereas in fibroid, it will be static over maybe a month or maybe 2-3 months. It will be static. It will not change overnight. In case of fibroid, it will not change overnight. Whereas in case of adenomyosis, the size will change dramatically over a short period of time. Now, the pain. Now the pain. Now you will think and tell me whether the pain will be cyclic in case of adenomyosis or in case of fibroid. In your comment boxes now. So in your comment boxes now, tell me whether the pain will be cyclic in case of adenomyosis or in case of fibroid. In your comment boxes now. I will not move even as step till you will not give me the comment in your comment box. Why to post that? There are 3 dots. You have to. Is that there in 3 dots?
Yes.
So now the point is the pain will be cyclic in case of adenomyosis or in case of fibroids. Shobna, what are they writing?
They're writing
Adenomyosis. Very good. Show me the comment box. We are having an eye on the comment box also. See, this is the comment box. So I'm not reading the names, but I am getting about how many? About 20 comments of adenomyosis. Dr. Harvinder, Dr. Veena, Dr. Komal, Dr. Shraddha, and others are posting adenomyosis. Very good. So in case of adenomyosis, this pain will be cyclic. What will be the pattern of the pain in case of fibroid? In your comment boxes again. Will it be cyclic? Yes or no? No. What type of pain will be having there? Shobna?
no comments here.
Why no comments? Think. Will it be cyclic? No, it will not be cyclic. Now the question is, no, don't post. No. We know that it will not be there. Cyclic pain will not be there. What type of pain will be there? Dr. Komal, very good. And others are also now coming. Dr. Chetan also, very good. Dull pain. Now I am adding one more point, dull and persistent pain. Now in case of fibroid, we will be having dull and persistent pain. So this is not a session over here. This is not a class what we are taking right now. This is a question and answer session. That is what I am saying. This is a question and answer session for our registered candidates. So this way you can make out what where is. Next question from Dr. Dinanath is that how to scan ductus venosus and cleft palate in case of a term pregnancy. This is over here. I showed this on the slide also. So the question is that how to scan a ductus venosus and the cleft palate in case of a term pregnancy. Anybody who has completed the detailed fetal ultrasound, come forward, raise your hands. I am repeating. Anybody who has completed the detailed fetal ultrasound, please come forward. Please come forward. So by forward, what I mean, you have to raise your hand, not the physical hand, not this hand. There is an option in the more to raise the hand. You have to click over there. We will unmute your system and we will get communicated. We will interact with each other. Hurry up. We are running short of time. Hurry up, please. Hurry up. Dr. Abu MD. Dr. Abu MD. Dr. Chintan has raised the hand. We are sending the unmute invitation. Accept the unmute invitation, and you will get a notification to accept it. Accept it on our, and on accepting you have to say hello. Dr. Chintan, we are sending you also. Dr. Chintan Chaudhary and Dr. Abu, we have sent you an invitation. Dr. Chintan, say hello.
Hello, sir.
Yeah. Have you completed the course which I quoted, the fetal ultrasound? Yes or no?
Yes, sir.
Yes or no?
Yes, sir. I have, sir.
Done. Your name is Dr. Chintan Chaudhary, right?
Yes, sir. Yes, sir.
Dr. Chintan. Okay, hold on. Tell me what should be the scan plane if you are taking a ductus urology. What should be the scan plane? We have discussed this in great detail on server course. Yes or no?
Yes, sir.
Now tell me the scan plane on which you will be taking the BV.
So mid-sagittal section.
Mid-sagittal, very good. So the mid-sagittal is the section by which I can get a ductus venosus. Now the point is, when can I see a complete profile of the fetus? I mean from head to toe. Will it be term or somewhere at 18 to 20 weeks?
So 18 to 20 weeks.
That is why we are taking level second scans at 18 to 20 weeks, because we are seeing the complete profile of the fetus. So the point is, I'm coming to the question. So the point is, at term, it is a bit difficult. It is a bit difficult. So don't rely on the mid-sagittal plane if the patient is near term. You will not get a mid-sagittal plane. Why? Because the fetus will not come on screen. I mean, the complete fetus will not be on screen in one frame. Am I right or wrong? Now, Dr. Chintan, you will think how to trace, how to get the ductus venosus near term. Where from I will be tracing? From umbilical cord insertion. Yes or no? From umbilical cord insertion, then I will go up. I'm not going upstairs. I don't have to go somewhere. I will see up to heart. What I am seeing rather in between heart and the umbilical cord insertion? What I am seeing? Hurry up, Dr. Chintan. Turbulency of flow. Why there is turbulency of flow? That is the ductus venosus. We are having multiple practical videos on our server how to scan a ductus venosus. I am requesting you to watch these classes, and if you have watched it, if you are completed, you can revise if the course is active with you. So that way you can scan a ductus venosus near term. Now the second part of the question posted by the candidate is that how to scan a cleft lip and the palate. Now what will be the section? Will this be the section or will this be the section? I mean, the complete mid-sagittal section is the section for the facial profile. Dr. Chintan, yes or no? I may be right, I may be wrong. Should I repeat the question? Dr. Chintan, I am...
Complete facial profile of the fetus, we need the mid-sagittal section, sir.
Okay, now put your hand on your face and show me the mid-sagittal section. I want to see mid-sagittal section on your face. Put your hand on your face like this or like that. How the mid-sagittal section is cutting the body. Now, like yeah, speak up. Speak up and say it is like this.
So it is like this, sir. So it should be cutting.
Now see to me. If you are cutting a slice like this, What actually you are cutting? You are cutting like this, right? That is why the ductus venosus will come on your screen, right? Now I want to see these two orbits. I want to see this lip, upper or lower. What should be the section? This or that?
So this should be this.
Say sorry.
Yes.
So no way you can take the section. I mean, the section is not the mid-sagittal section, but what is that section called?
Coronal.
Coronal. Now this is the coronal section. By taking a coronal section, only and only coronal section is for facial profile. Got it? Now, how to take a coronal section? That is again one class on our server. Yes or no? You have completed the fetal ultrasound. That is what you quoted me. That is why I muted you. There is complete one, if not two classes, how to take a coronal section. I am giving you a brief. This is the mid-sagittal section. Both mid-sagittal sections and the coronal section like this, they are meeting at 90 degrees. Now see to my hand. So it means that you have to rotate your probe. Now, Dr. Chintan, will you be only merely rotating the probe or you will be sliding also? Recall the class.
So only rotating the probe, sir.
No.
And slide.
Yes. Yes. Recall the class. You have not only to rotate the probe, but you have to slide, because the face and the mid-sagittal section is now you are dealing with a grown-up fetus. So you have to slide the probe also. Now, how much I have to slide, that depends on how big the head is. Got it? So the point is, complete mid-sagittal section is not the section for the facial profile. That is coronal, and coronal. How to take the coronal scan? That is the class on our server. Please repeat that, and I gave you the brief also. Next question. Dr. Chintan, are you a gynecologist?
Yes, sir.
Okay.
Yes, sir.
Let me take a gynae question if I am having. Yeah. Dr. Prakash is posting a question. What should be the which axial plane we should measure BPD at C? Now tell me, Dr. Chintan, what should be the section? This is the question which we are discussing, which is posted by Dr. Prakash. What should be the which axial section? First, tell me how many axial sections you are having.
The 3, sir.
Name 3. Others in comment box now. Name 3. Transthalamic. Next.
Transthalamic, transcerebellar, and transventricular.
Very good. So 3 sections we are having: transventricular, transthalamic, and transcerebellar. Now, when you are taking a biparietal diameter, should I draw this on board? Dr. Chetan, yes or no?
Yes.
I will go later on. First, let us discuss. Now, when I am taking a mid-sagittal section, this axial section, am I seeing a line in center?
Yes, sir.
That is fax cerebri, right? Now, while taking a BPD, when I am taking a BPD, I should see the maximum length of fax cerebri. Now tell me, I am having a counter question, because in that counter question lies the answer. Will you be able to see the complete line when you are in a cerebellar section? Yes or no?
No, sir.
Try to understand the question. Should I repeat the question?
No, sir, I understood. The whole
Will you be able to see a complete line when I am in transcerebellar section? Yes or no?
No, sir. No, sir.
No, very good. Now, will you be seeing more of the central line when you are cutting more centrally? That means transthalamic, yes or no?
Yes, sir. Transthalamic.
Now you know, but my job is here to prove that you are knowing. So this is the implementation of your theory. Ultrasound is nothing but the implementation, but you should know the theory. right? So the answer is, oh, I am very sorry that my answer is always very long. So the answer is not the transcerebellar, but somewhere at the level of the transthalamic section. Next, you are a gynecologist, right? Very good question for you. It is actually for me. I will be helping you. Okay. I feel this is the again Dr. Prakash posting the question. I feel difficulties to locate ovaries. Please listen to answer question first. This is the copy pasted question. Copy pasted question. I feel difficulties to locate ovaries in some patients due to away from scan area or hidden by bowels or other structures. How to overcome in this difficulty, especially in TVS probe? Have you got the question, or I should repeat the question? I'm summing up the question. Let me summing up the question. That candidate, Dr. Prakash, is posting that sometimes the ovary is away from the uterus, and when I'm inserting the probe, I am not getting that ovary because that is away from the transducer. Now, Dr. Chintan, being a gynecologist, tell me honestly, I am using the word honestly, are you always getting ovary in each and every patient?
No, sir.
No.
Not always.
No. Why? Because of this thing. Because ovaries location is not fixed. That is what we are teaching you since beginning in the gynecology ultrasound. That ovarian location is not fixed. Now, what you have to keep in your mind is that first, the field of view. Now see, try to understand. First, the field of view. The field of view is more in TAS or in TVS. Dr. Chintan, the field of view is more in TS or TS.
TS, the field of view will be
TS is showing you a broader field. So make a habit from tomorrow onwards that you will scan on TAS first, then will switch to TBS. Because TAS will give you an idea of the location of the ovary. You got it? Now the point is, you know that ovary is not far from the uterus, then you will expect the ovary to come on TVS. Everybody is thinking that ovary, that this TVS is something superior to TAS. No, it is not. It is only superior resolution wise. Field of view is less. So always make a habit that scan a patient on TS, have an idea of the location of the ovary. Ovary even can be somewhere in the cul-de-sac or near the cul-de-sac. Then you know. Now see the beauty. We'll ask the patient to micturate first, then come back. Now you know that the ovary is towards the cul-de-sac. Now you will tilt toward the cul-de-sac, then you will get it. Now, if you will merely do these jobs, by having an idea that ovary is next to the uterus, it may be there, but in some cases, as posted by Dr. Prakash, may not be. That is one point. Second point is that you can see the iliac vessels. You can trace from the iliac vessels. Iliac vessels will be not always, but usually will be like a base of the ovary. Okay. Last question. Then you can mute yourself if you want. Depth and frame rate. Dr. Chintan, this is the question posted by Dr. SN. Is that our depth and frame rate same? Both are inversely proportional. Now tell me what is depth and what is frame rate. Dr. Chintan, you have any idea of depth? What is depth?
So I know the frame rate It's like
What is frame rate? Okay, tell me what is frame rate.
there's a consecutive images which are taken in a particular.
Very good. You know it. Now the frame rate means how many frames per second. That will decide the quality of the image. Yes or no? We are not going to draw this because this is already covered in physics and machine settings. We are having a 1 month course of physics and machine settings. Now the the overall resolution of the machine depends on how many frames per second, right or wrong? Now, if your intention, your target should be to increase the frame rate so that the resolution will increase. Now, question. Dr. Chintan, think. Question. When you are increasing the depth, are you decreasing the frame rate? Yes or no? Should I repeat?
Yes. Yes, sir.
Should I repeat
They
or
are,
this is the answer? Yes.
No, sir.
I'm repeating the
They're
question.
directly proportional.
I'm repeating the question for you. Hold on. Listen. By increasing the depth, what will happen to frame rate? Will it decrease or that will increase? Tell me this way, decrease or increase. I am repeating the question for third time. With increase in depth, what will happen to frame rate? Will it increase or decrease?
Decrease.
Others in comment box.
Decrease. Sir.
Decrease, yes. Now, with decrease in frame rate, what will happen to resolution? Increase or decrease?
The increase. The resolution will increase.
Will?
Increase, sir.
Let me stick here. Shobna. Dr. Chintan, see to my eyes. See in my eyes. What will happen to the resolution if frame rate will drop?
The resolution will become poor, sir. If the frame rate will be dropping.
Very good. Now your mind is working. Now the point is, with increase in the depth, what will happen to resolution?
It will be better, sir. It will also be poor. Again, it will be poor.
Very good. You got the point? It means that your aim should be to have more depth or lesser depth?
So lesser depth.
Lesser depth. So because with lesser depth, the resolution will go up, up and up. Now, I'm very sorry. My answers are very lengthy. Now, our depth. Now coming to the question. Are depth and frame rate same? Both are inversely proportional? Yes, they are. Now see, I could have answered in one word, yes. But I gave you a detailed answer so that you can recall the things and you can revise it also. So yes, they are. Now, the second part of the question means what to do when organ is deep and to upgrade the resolution. Now, that doctor wants to know, what if I have to go deep, but I want to increase the resolution? You cannot. Now see, if you have to climb high up, I'm just giving an example. If you have to climb high up, you cannot go on a high heel. You have to take that off. Otherwise, you will fall down. Same is true here. If you want to go deeper, that will be at an expense of resolution. Got it? Now, you want to increase a specific areas resolution. It is not actually the resolution. The clarity, I will say. Then the focal zone, move the focal zone to that target. Again, repeating, this is the question and answer session, not a session which we are taking, not a class, actually, not a course, because these classes are available on our website. We are today taking question and answer session from the registered candidates. Now, the last question, Dr. Chintan, clear? Okay, I'm muting you. Now, the question is features of testicular microlithiasis. Features of testicular microlithiasis. Now, first of all, microlithiasis, we are running short of time. So features of microlithiasis, testicular microlithiasis are, sorry, first of all, there will be hyperechoic dots like in scrotum. But they will be very small, 1 to 3, you can note it down, 1 to 3 millimeters. Without posterior shadowing. Why no posterior shadowing? Why there is no posterior shadowing? Because it is very small, 1 to 3 millimeters dispersed throughout the scrotum, testicle. That will be the testicular microlithiasis. Now there is now you have to see how many dots are there per frame. Then you can not actually grade it, but label it. Just hold on. Then you can label this as limited TML, testicular microlithiasis. It is like whether this is mild, moderate, or severe. Here we call it limited, classic, and diffuse. Now, whenever you are taking one frame means one slice, you are seeing less than 5. That will be limited. So note it down. Limited is 5 dots, 5 calcifications in one frame. No, not in one frame, one slice. Then is the classic, where there is greater than or equal to 5. It means that 5 and more, that will be classical. And diffuse, there are numerous, you cannot count it. So that way you can label this as limited, classic, and diffuse microcalcifications. Microlithiasis also and microcalcifications also. That is the same one and the same thing. What was the next question? Yeah, Dr. Papu is posting how much is the length of the kidney, liver. So please complete your topics. It is taken in great detail in abdominal ultrasound, the complete length, organ-wise. I am giving you a brief like liver. You are not completed yet, liver. I am damn sure, I am 101% sure, because these things are in detail on our server. You have not completed, you have not even touched the abdominal ultrasound because these things are already detailedly there. So I am giving you a brief. A length of the kidneys approx at 10 centimeters. Which one will be larger? You know, the left one. Than the right one. Right one will be about 8 centimeters. But there is the age also. You have to see the age. And if you are dealing with 2 months, for example, 2 months, this baby, then it will be approximately 5 centimeters in length. And from 2 to 6, it will be 5. You can note it out. 5 up to 2 months, 5 centimeters. Then it will be 5.7 centimeters. From 2 to 6 months, and from 6 to 1 year, 6 months to 1 year, it will be 6.2. So there are charts. You can download any chart and you can paste that chart in front of your machine, because these all measurements cannot be recalled whenever you are scanning a particular patient. And for adults, it is about 10 to 12, left one. 10 to 12. Now it again depends on the stature of the patient. If you are scanning a South African patient, you will not even expect 8 centimeters kidney in South African patient. You will expect more than 10. But if you are scanning a Chinese patient, even 7.8 is normal. Even 7.5 is normal. So it depends on the stature of the patient, but on an average, it is in between 8 to 12 centimeters in a matured adult. This is detailedly covered in the this KUB course. So now that was the kidney. What was the next one? So the next one, please mute your microphones. If anybody is not muted, mute yourself. Now the liver, where to scan the liver at the mid-clavicular line. Again, this is in detail in the abdominal course. And in on an average, it is about 15 centimeters in length, and in depth, it will be about 13 centimeters in length. So please complete your topic before posing the question, because whatever you are posing right now is already covered, not covered, is already there in the course. So please complete the topic. Then whatever questions you'll be having, it is my pleasure to have an interaction, and I will be more than glad to take these questions in detail. Thank you very much. So you will get a notification of our next session for our ongoing registered candidates question and answer session. I am repeating again at last I am repeating again that this is not a course what we are taking right now. Right now we are taking question and answer session for the registered candidates who are right now registered with us for our server based courses. Thank you very much. God bless all of you.